All right. Well, good morning, good afternoon, and good evening to those of you further east from us here. Welcome to the World Vision Global Health, Nutrition, and HIV Community of Practice guest speaker series, where we are going to talk today about where are we headed with HIV and adolescence. And today we have a special guest, Dr. Susan Tesede. I hope I'm pronouncing that correctly. Who is team leader for HIV and Adolescents for UNICEF. Tina Monique introduced us and invited her to this World AIDS Day Forum in observance of yesterday's Observance Day. So Tina Monique, why don't you unmute yourself, give us an introduction, and tell us why you brought Susan here to help us walk through HIV and adolescence.
Wonderful. Thank you, Sarah, and welcome everyone to the call. I bid you all a very happy World AIDS Day, and we'll talk a bit later about why we should be either happy or sad in that regard. I would like to first profusely thank Dr. Susan for agreeing to do this talk for us, even while she's on travel. She's currently in Geneva, and we are very appreciative of her carving out this bit of time to bring us this information. So Dr. Susan was a presenter during the International AIDS Conference in Melbourne in July, and she presented on HIV and adolescence. And it was very good to have her to bring this talk for us because quite often this adolescence as a subsector of society can be overlooked. But we all know, and if we recall back to our senior year, that adolescence presents a unique set of challenges all in of itself, just in terms of navigating adolescence, much less navigating adolescence with HIV. And so this is the unique area of expertise that Dr. Susan presents to us today. So as Sarah already told us, Dr. Susan is the senior advisor and team leader on HIV and adolescence for UNICEF. She's based at the UNICEF headquarters in New York. So since 2009, she's contributed to global level evidence generation, technical guidance development, advocacy, and global partnership development towards a stronger global response on HIV in terms of prevention, treatment, and care in the adolescent age group, the 10 to 19-year-olds, which are often largely neglected, as we've already stated. She's coordinated a series of studies, including documentation of global practices in the care of adolescents with HIV, mathematical modeling, and also dealing with deaths in adolescents in systematic review through the London School of Hygiene and Tropical Medicine. So Dr. Susan has over 18 years of experience in working on adolescent sexual and reproductive health, of which 16 of those years focused on HIV. She holds a doctorate in epidemiology and population health from the London School of Hygiene and Tropical Medicine and a master's degree in public health from Boston University. With that being said, I will now hand the floor over to Dr. Susan. Thank you very much.
Okay, thank you very much, Tina Monique, and to Sarah and everyone else at World Vision for your kind invitation to me and to UNICEF to share some thoughts with you. I just want to check in that you can hear me okay, because I know some people are experiencing some echoes. So if you could just signal to me that you can hear me okay, I'll be happy to continue.
You sound great, and I've passed you the presenter ball, and so within WebEx, that gives you control over your own slides. Just above your slides, you'll see a little text box with a 01 and an arrow to the right, and you can move, that's how you forward your slides. But we hear you wonderfully. Thank you for joining us.
Okay, thank you. Thank you for pointing that out as well. All right. So at UNICEF, we're especially delighted to have the opportunity to share some thoughts with you on HIV in the second critical decade of life with this group, and to discuss with you during the course of this webinar and in the series that follows what some of the opportunities are from your perspective to help end the HIV epidemic among adolescents. I'd like to begin by acknowledging the contribution of the teenagers and partners, the adolescents numbering over 1.2 billion all over the world, on whose behalf we advocate and many of whom we work quite closely with in our programs across the over 190 countries where UNICEF has presence. I'd also like to acknowledge the contribution of my colleagues from a number of country offices, but also sections in our headquarters team that have contributed towards this presentation. My presentation today seeks to provide an overview of HIV and adolescence and to explore a number of opportunities in areas of your work that can help bring further focus, efficiency, and effectiveness to our collective investment in adolescence. And we know that there is a lot of work that's already going on, and I hope that this discussion, this forum, will help to shed some light around some of the opportunities for better impact and results through improved collaboration, integration with existing opportunities, and continuity of programming to build on the successes that we've already started to see registering in the early years of a child's life, and ensuring that those successes are protected and reinforced as children grow into and evolve through adolescence. So I'd like to start by looking at the numbers and what we know. Now, even while data on adolescents aged 10 to 19 years remains quite poor globally, the best available estimates that we have on AIDS-related deaths, and this data was released first about a year ago when UNICEF launched its 6th stock-taking report. The best available data suggests that AIDS deaths may not be slowing down or declining among adolescents as it seems to be doing in other age groups. You'll see in this slide the AIDS-related deaths in age group 0 to 4 has dropped most remarkably. That's the orange line at the top. And similarly, we've seen decreases in the age group 20 to 24 in the green line, and to some degree amongst children aged 5 to 9. But if you look at the red line, which represents the best available estimates for AIDS-related deaths in 10 to 19-year-olds or adolescents, we see quite a different suggested trajectory. And what this suggests then is that there's a need for us to focus our attention much better on treatment, care, and support of adolescents within existing national treatment scale-up plans. And this needs to be done with urgency because of the suggested direction of age-related deaths we're seeing. It's a marker of the potential impact of the fact that adolescents are being overlooked, as Tina Monique mentioned in her introduction. Now, if we look further in the next slide at the distribution of infections in adolescents globally, what we see is that, in fact, nearly half of all the adolescents living with HIV are in just 6 countries. According to the WHO report launched earlier this year, The Health of the World's Adolescents, HIV is now the 2nd leading cause of death amongst adolescents globally, and it accounts for just over 300 deaths per day in adolescents at a time in their life where they really should be experiencing relatively good health, building on the positive gains made in their health in early years. Our analysis of available data from UNAIDS in 2013 suggests that of the 35.3 million people living with HIV in the world today, about 2.1 million are adolescents, and Sub-Saharan Africa accounts for about 83% of all adolescents living with HIV. As I said, about 7 out of 10 of all adolescents living with HIV are in 7 countries shown: South Africa, Nigeria, Tanzania, Kenya, Ethiopia, India, and Uganda. And it's clear that success in ending AIDS in adolescents will rely largely on our ability to mobilize more intense and effective action on focused geographic areas where and in populations among whom HIV is concentrated. In these countries that contribute so significantly to the global burden of HIV in adolescents, we're going to have to do a lot better at reaching adolescents that are most vulnerable with effective technologies for prevention, at reaching those adolescents living with HIV, ensuring that they have opportunities for diagnosis, for testing and diagnosis, initiation into care and treatment, and support to ensure that they're retained in care. But critically, in addition to the prevention and sharpened testing and treatment approaches, we have to do better at protecting and empowering adolescents themselves to ensure that we reduce their vulnerability and protect their dignity and quality of life. And I'd like to move on to the next slide because I want to go a little bit more into who we should reach in order to have better impact in the HIV epidemic in this population. This slide shows the distribution of new infections between adolescent girls and boys in 20 countries where close to 85% of all new HIV infections occurred in 2012. It shows the heavy burden on adolescent girls in sub-Saharan Africa, and it reminds us of the significance of key populations in adolescents everywhere. I apologize, the slides up there show, in particular, the distribution of infections by age in 4 high-burden countries. But the difference that you see between the purple and the orange line actually illustrates the difference in risk that occurs very early on in the adolescent period among adolescent girls. But it also reflects the opportunity that we have through more effective early intervention in the lives of adolescents, and in sub-Saharan Africa, particularly adolescent girls, in order to change the trajectory of the epidemic in adolescents and young people themselves. The reasons for the disparity that you're seeing has been clearly documented, and they include low levels of knowledge, specifically around sexuality and adolescent development, and sexual and reproductive health. They include structural factors such as early dropout from primary schooling, lower enrollment and lower completion rates for secondary schooling, and behavioral factors and social norms such as early sexual debut, child marriage or early marriage, age-disparate partnerships as well. All things that we can change, but we can only change if we have truly collective and community-wide engagement and commitment to change in many of the structural issues that contribute to the vulnerability of adolescent girls in particular. But we also need to take special attention to address the vulnerability of boys. In the United States, for example, in 2012, adolescent boys accounted for more than 60% of new HIV infections in adolescents between the ages of 15 and 19. And in the USA, vulnerability is particularly acute among young males who have sex with males, transgender women, and among those who use drugs. Again, pointing to groups of adolescents who are not only overlooked because of their young age and the presumption of their health, but also overlooked very often because the systems simply aren't picking up the data and using that data to inform programming to reach these young people effectively with the services and interventions that are available to reduce risk of infection and to lead to better impact. So I'd like to speak a little bit more about these adolescent key populations because wherever we're working, we are observing continued challenges from service-level challenges through to policy and legislation that have significant impact on outcomes in these adolescent populations and on their risk for HIV and quality of life and survival. And we need to ensure that our interventions take into consideration their specific needs related to behavioral prevention and social engagement. In Asia and the Pacific, in the countries where we work, more than 95% of new infections among adolescents are believed to have occurred among members of key population groups. Just to give an example, in Myanmar, HIV prevalence was found to be 7% among adolescents aged 15 to 19 who injected drugs, while in several countries in Eastern Europe, although what we see suggests a small but important proportion of injecting drug use beginning in adolescence, we're also seeing that that people who inject drugs between the ages of 15 to 24, adolescence is the period when a significant number, up to 30%, begin to initiate drug use. And so again, the adolescence period, as we saw with the graph in sub-Saharan Africa, is that period where you start to see the disparity or the departure in risk starting to present itself among adolescent girls. Among key populations in many parts of the world, we see adolescence as that period where we have the opportunity to intervene and change the trajectory through early intervention to support prevention and behavioral change. But vulnerability of these key populations is compounded by severe social stigma, as well as punitive legal frameworks and harsh law enforcement that often acts as a deterrent to accessing services and acts counter to the provisions and recommendations of even the best legal frameworks that we have, such as the Convention on the Rights of the Child, which place the obligation to protect as well as to provide comprehensive and adequate, effective health care in addition to the right to protect from harm. And so the question is, what evidence do we have to guide our actions for adolescents, given the numbers that we have indicating the challenges with HIV prevention and treatment and care? Now, in Melbourne at the International AIDS Conference, we were very pleased to be able to release a special journal supplement on program and operational evidence on what works for adolescents. This evidence was released in a publication providing a clear understanding of areas that need focus for us to achieve results. Results in the form of reduced incidence, reduced AIDS-related illness, and reduced AIDS-related death in adolescents. The clarity in the articles published in this supplement came at a time when we're starting to see widespread acknowledgement of the need to critically assess the efficiency of allocation of the limited resources for HIV response and to prioritize investments in those interventions that are core to delivery of impact in those three areas: reduction of incidence of HIV, reduction of illness, and reduction of AIDS-related mortality. Now, the entire supplement is available online, and I will share a link to that. But I'd like to highlight among the articles two in particular. One that was authored by Mavid Zenge et al. And this is a systematic review of systematic reviews that presents evidence primarily from trials and intervention evaluations looking at adults, but highlights those trials and critical evaluations that have generated high-quality evidence illustrating the potential efficacy for results in adolescents. One challenge that this systematic review reveals is the limited amount of evidence that we have around operational delivery of interventions. In other words, how to effectively deliver interventions to adolescents. This links to the fact that many of the trials and studies that qualified to be included in the systematic review did not, in fact, include adolescents themselves, and so were not able to demonstrate conclusively what needed to be done differently to ensure that the interventions work optimally in adolescents. To address this gap in knowledge, several additional articles were commissioned and published in the supplement, documenting experiences and lessons learned from scaling up implementation of strategic interventions to reach adolescents. These included, as you see there, reviews looking at voluntary medical home circumcision, a review looking at lessons learned from scaling up contraceptive services, a review of lessons from scale-up and delivery of HPV vaccines, and then a review looking specifically at adolescent girls and programming for adolescent girls, and one looking at interventions and programming for young people populations. Now, the systematic review itself came up with 3 key recommendations, and I'd just like to highlight the core messages from this. What you'll see here in the green boxes are interventions that were coded as having consistent behavioral or biological effects and moderate to high quality evidence for effectiveness. And you'll see these in the 4 boxes on the top left-hand side. Now, these interventions are recommended for large-scale implementation. They include biomedical interventions such as ARVs for PMTCT or ART itself, condoms, VMMC, opiate substitution therapy, and others that have been referred to as high-impact HIV-specific interventions. All of these contribute to specific biological outcomes critical for HIV incidence reduction and morbidity and mortality reduction. But they also include interventions that influence behavioral outcomes, such as individual, peer, and community approaches that can be used to increase the use of clean injecting equipment among people who inject drugs, for example. Now, the second set of interventions were coded as yellow, and these are, in short, interventions that show promise, that require additional studies showing beneficial impact before large-scale implementation can be recommended. The examples of these at the time, and remember this, the systematic review was undertaken in 2013 and published this year. So the examples included in the systematic review of interventions showing promise included topical PrEP for HIV prevention in women and the use of supervised injecting centers. Now, since this time, in fact, additional trials have been undertaken looking at the use of topical PrEP, and these are being done increasingly through demonstration projects so that we can learn more about both the efficacy and the operational approaches to optimize the effectiveness of topical PrEP, at least in serodiscordant couples. In MSM, the use of topical PrEP has been shown to be beneficial, and recommendations, national guidelines have already been developed and cleared, for example, in the United States for provision of PrEP to males who have sex with males. Now, the third group of interventions was coded as orange, and these are not recommended based on the evidence that was available at the time of the review. Further, high-quality research is needed to establish the beneficial biological and behavioral impact of these interventions in order to recommend their programmatic implementation. And these include, for example, delivery of HIV services for young people in standalone centers. In other words, in centers that are not integrated to existing service provision sites. The evidence for the use of standalone centers for youth did not come out strongly at all in the systematic review, and the recommendation seemed from all the different evaluations and reviews that we looked at to point to the importance of integration of youth-specific services in existing sites and in investment in existing sites and facilities to ensure that they are more adolescent or youth-friendly as a more sustainable and effective approach. And another example was the delivery of in-school HIV prevention education as an intervention to change biological outcomes. There's evidence that the integration of in-school HIV prevention education is critical for knowledge outcomes and is helpful for behavioral outcomes, but the evidence for the use of in-school prevention education to change biological outcomes was not strong. And so the interventions, again, in orange, were not recommended. for wide-scale application. Now, I'd like to touch on a further area of evidence that has grown in the last few years, and this is the area related to social protection. The graph here shows evidence from evaluation of a national cash transfer program in South Africa. And this is one of several evaluations of national cash transfer programs that have shown significant HIV-specific impact that can be achieved through adolescent and youth-friendly social protection programs, in this case in the form of reductions in transactional sex or the selection of partners, in other words, age-disparate sex. In looking at both indicators, when you compare the outcomes in the adolescent girls who received no cash transfer in the gray bar with the girls who received some form of child grant in South Africa, shown in the blue bar, you'll see that the incidence of both behaviors, transactional sex on the left and age-disparate sex on the right, was far lower in the group that received the cash grants. But cash is not the only input that's required or that can make a difference in particularly high-risk populations. What this study showed is that if you look at the graphs from the far left to the far right, there are other critical structural factors that come into play in contributing towards vulnerability. In this case, this study looked at the differences in transactional sex or engagement in transactional sex or reported engagement in transactional sex amongst adolescent girls in a healthy family compared with a family where at least one parent had HIV, compared with a family in which the adolescent girl experienced abuse or repeated hunger or deprivation. And then they looked at girls who experienced a combination of these factors. In other words, lived in a household with an HIV-infected parent, as well as experienced a combination of repeated hunger and abuse. And what was found was that the combination of these factors really had a significant effect on the vulnerability of these adolescent girls. And so in addition to thinking about interventions through service provision for prevention, treatment, and care, in addition to ensuring that we support innovative approaches such as the use of cash grants or social transfers, there has to be a significant investment in the environment, the structural environment around adolescents in order to have the most significant impact in reducing their risk. And at this point, I just wanted to break to share a story about the importance of care. And I'm not sure, Sarah, if you have, if we're able to switch to the video. Could I just check in with you?
I'm sorry, Dr. Susan, I don't think we figured out a way to have it stream over the internet, but we will definitely circulate with the notes. My apologies.
Okay, no problem, no problem. Just to tell you what I had hoped that we would be able to see together is the importance of combining investment in care on outcomes in adolescence, attitudinal outcomes, behavioral outcomes, but their overall ability, ensuring their overall ability to thrive just by addressing the issue of care through critical gatekeepers, who will include parents or primary caregivers, family members, peers, as well as, for those in school, teachers, as was shown in this video, and for those who are out of school, partners or significant others, and just by making sure that there is greater literacy about HIV, that there is better understanding around the importance of support, care and support in the community to minimize the risks of discrimination and exclusion. All of these having profound impact on the choices, the decisions, and the quality of life of adolescents. And so with that, I'd just like to move quickly to what we're calling for, which is a smarter investment in responses to HIV in adolescents. Now, taking the evidence that that we have on intervention, we've asked the question about what this would mean in practice, and we've modeled what the potential outcome could be of a shift from programming as it is now, which we're calling scenario 1, and we've compared that with what the result would be if all countries proceeded to start to scale up access for adolescents to core or high impact interventions moving towards 2020. And clearly what you see on the slide here is that regardless of the setting, whether you're working in a generalized context or a context with a concentrated epidemic, smarter investment delivers better results. It delivers better results in terms of new infections, but when we did this modeling, we looked too at survival, at age-related death, and smarter investments save more lives. And what this means is that collectively, we have to start looking critically at whether we're investing in the right groups of adolescents, those in whom we're seeing the greatest vulnerability through new infections, whether we're investing in the right combination of interventions, those interventions that are going to, based on the evidence that we have, are going to be most effective at reducing new infections, at reducing morbidity and mortality, and whether we're doing this at the right scale to achieve impact in the countries. Now, that brings us obviously to the question of how much to invest. And what was interesting when we did this modeling is that we found that quite uniquely to adolescents, when we look at the 3 areas, the programs, all those core high-impact interventions, the enablers, the investments in mobilizing and engagement, and the sector synergies, we found that a significant proportion of the interventions for adolescents need to be in the areas of synergies. In other words, education, protection related investments. And this makes sense when you think about, again, the importance of care and where adolescents live and on whom they depend, the systems on which they depend in order to survive and to thrive. So quite unlike the adult population, where there was far less investment required in the sector synergies, for adolescents, investment in the sector synergies is critical. And this is where, again, I think for World Vision, because of your work close to communities, to influence community awareness and care and capacity, this is an area, again, where there's a huge opportunity for complementarity in terms of results for adolescents. Now, I'd like to turn now to the question of mobilizing adolescents for change, because based on what we know in terms of the epidemic itself and the opportunities we have to make a difference, we've been engaged over the last year in trying to mobilize global action to make a difference and to make a real difference in adolescents. Specifically, what we're trying to do is to mobilize a global partnership to simply end AIDS, the AIDS epidemic in adolescents. And we want to do that through a global push, a global agenda that we're referring to as All In. All In is quite simply just a wake-up call to the AIDS movement and to the global community to take urgent action about this neglected population, adolescents aged 10 to 19. So All In is an agenda that has been convened by UNICEF, the executive directors of UNICEF and UNAIDS, with a broad range of partners. And the intention is to mobilize the global community and country-level partners to build on the evidence that I've just presented and that we have at the country level, to build on technical resources available at the country level, the operational knowledge that we have, in order to take 4 key actions. First of all, to assess the epidemic in adolescents at the country level in order to sharpen the adolescent components of national plans. Secondly, to scale up effective interventions and improve their impact using appropriate innovation. Thirdly, to work with adolescents and youth to challenge and change the social context and the factors that make adolescents vulnerable to infection and contribute to their exclusion from services and support. So really partnering with adolescents to make a change to the social context. And fourthly, to advocate and communicate in order to successfully mobilize technical support and financial resources to end the AIDS epidemic in adolescents. So All In is a global initiative, and what we would like to see is all countries considering and taking forward priority action to end AIDS in adolescents based on the data and evidence that they have to help determine critical actions and results that are appropriate to their context. There are 12 lead countries that have been identified, and they represent the countries contributing to the vast majority of AIDS-related deaths in adolescents and the majority of new infections. Specifically, the 25 countries contribute to 85% of new infections and to 90% of AIDS-related deaths. The group of countries also reflects the global heterogeneity of the AIDS epidemic in adolescents. The countries have been selected to reflect the large number of high-burden countries that were shown in that initial graph that I shared, the donut-shaped graph. 18 of these countries are in sub-Saharan Africa, and 7 of the countries are outside sub-Saharan Africa. And the 7 outside of sub-Saharan Africa include Brazil, Haiti, India, Indonesia, Iran, Thailand, and Ukraine, where across them the vast majority of infections in adolescents are among adolescent key populations. So we've spent quite a bit of time, and we are in Geneva this week to review with partners a strategic framework for All In that underlines the message around key targets for a stronger, sharper global agenda on adolescents. The 2 targets are to reduce AIDS deaths by expanding treatment coverage in adolescents to 80%. This would be in line with the global retargeting exercise that's being built around the principle of 90-90-90, in other words, achieving 90% knowledge of HIV status among people living with HIV, 90% treatment coverage among those who know their HIV status, and 90% viral suppression among those on treatment. So 80% treatment coverage in adolescents would correspond to that particular principle, bringing a more equitable result towards the adolescent response. The second target that we've defined is to reduce new HIV infections among adolescents by 75%. Now, to achieve these targets by 2020 will mean that we have to scale up a combination of interventions and access to these interventions for adolescents by 2020 to put adolescents on track to end the AIDS epidemic by 2030 in adolescents. So this particular framework emphasizes the need to focus on adolescents most in need of HIV prevention, treatment, care, and support. In terms of prevention, adolescent girls in sub-Saharan Africa are the primary focus in that region, while adolescent key populations, adolescents who use drugs, adolescents who sell sex, adolescent males who have sex with males, and transgender adolescents are among the key populations affected by HIV the world over. And we want to see countries taking much more deliberate looks at the epidemic and response to these particular adolescents so that we do not exclude them from the response and the opportunity to save lives. With respect to adolescents living with HIV, we'd like to see countries look more deliberately at the needs of adolescents who are vertically infected and in need of support as they transition into adolescence, as well as the needs of adolescents who are behaviorally infected, so that we do better at expanding opportunities for testing, linkage to treatment and care, and support for retention. So as a result of this week, what we're hoping is that we will come away with agreement across a broad partnership for use of this framework to hold countries accountable, beginning with the 25 lead countries that have been identified, so that we can work as a community with these countries, first of all, to establish a data-driven plan for scaling up a critical core package of interventions for adolescents to lead to these results in each of the 25 countries. The improvement of data is a strong element, underlying element of the work around All-In, as is the engagement and partnership with adolescents themselves, not only as recipients of the support through the interventions and plans that are drawn up, but also as partners in the design, the planning, and the monitoring of the interventions and response at the country level. So with that, I'd like to end my presentation by pointing to a number of useful resource documents that I've used to inform this presentation and that I'd like to use to acknowledge the work that has gone into strengthening guidelines and global policy for action in this population. And I hope, it's our hope that that with this information, you have enough to stimulate further discussion internally within the World Vision team, but also discussion with your partners wherever you're working to help advance this work, improve the quality of the work on adolescents, to strengthen national planning and monitoring around adolescents, so that we can see much better outcomes in this population by 2020, and certainly see an end to the AIDS epidemic in adolescents by 2030. Thank you.
Thank you so much, Dr. Susan. We really appreciate that talk on this very timely topic, especially as we acknowledge that perhaps some of the programming areas that you presented that haven't been as successful as we'd like to see, and we consider what revisions might be made to those programming areas so that we can have more successful programs for adolescents as we move forward. So we're about to go into a question and answer session that Sarah will so skillfully guide us through because she's so good with the chat box. But before we do that, I did want to recognize the presence of Ronnie Lovich, who's on the call. And Ronnie is the Vice President over at APAS, the Elizabeth Glazier Pediatric AIDS Foundation, that happens to be one of our global partners at World Vision in this area of HIV. So welcome, Ronnie, and we'll allow you just a second or two to greet the entire gathering as we move further into the question and answer session.
Oh, thanks, Tina. I appreciate it. This has been a really terrific session, and so many important points were raised. I hope that that mainstreaming adolescent HIV treatment into ongoing prevention, care, and treatment can be possible, but also finding those strategies outside of MCH services that we really need to roll out care and support at scale. Anyway, thank you to you and Susan for a great session, and thanks for giving me the chance to speak.
Sure thing. You're welcome, Ronnie. Okay, Sarah, over to you, please, to guide us through.
Okay, we had a few questions in the chat box. One coming from Ann Claxton. It's troubling to note that the behavior change interventions in institutions, whether they be schools, health facilities, or youth centers, were all in the orange in that review of interventions. This is what I'm referring to, that they're not recommended. Since service delivery through such facilities and institutions is thought to be one of the most effective means to reach adolescents as a group, what are some of the main factors that cause these to be ineffective?
Hello, can you hear me?
Yes, we can.
Yes.
Okay. It's true that we found in the systematic review that the quality of the evidence around these particular interventions, the quality of the evidence from programs in particular, was quite poor with respect to biological outcomes resulting from in-school behavioral change communication. In other words, for example, when we looked at studies that had looked at changes in pregnancy, we found that the interventions had very mixed results in shifting that kind of biological outcome. And so the result from this was, you know, there needs to be much stronger quality of evaluation of behavioral interventions. There was not sufficient evidence to suggest that they are shifting biological outcomes for us to be able to move them into the recommended categories from this review.
Thank you. There's a question here from Tina Monique, and maybe I'll flip back to the all-in slide. There we go. Are adolescents currently recognized as equal partners in the health service settings? And it looks here in this slide that it looks like adolescent as child participation is important. So are they recognized as equal partners? What work needs to be done in this area?
So just to make sure I understood the question, are adolescents equal partners in health service settings?
Are they recognized?
Especially in terms of some of the countries that you said are most heavily affected by the high burden of HIV or adolescents living with HIV. Are they recognized as equals in that setting, or are they, you know, denigrated due to age restrictions and customs and things as such?
Okay, I think that's an interesting question. We actually have we've just undertaken a quick consultation, email consultation through the partners that are meeting this week, and through them with their partners in each of the 25 countries to find out what their views are with respect to involvement of adolescents in program design, in programs in service delivery, in policy development and program monitoring. And across all of the countries, what we've heard back is that this is still, the engagement of adolescents is still being done very much at the level of program innovation. It isn't yet the standard for program delivery. Many of the countries and the teams that responded highlighted engagement of adolescents in service delivery and monitoring, for example, as innovations of particular programs. Again, pointing to the fact that it isn't yet given that that they should be engaged as good practice as peer educators in service delivery, you know, across the board. And so I think that there is still work to be done to advocate for engagement and partnership with adolescents. There needs to, and this is part of the effort that needs to continue around building adolescent-friendly services. So and that's why we see the opportunity through All In as critical in, if we are able to get countries to reflect more on this framework and to accept to use this framework as a way to report back on our work on adolescents, what we'd like to see over time is a deliberate effort to essentially institutionalize the practice of engagement, partnership, and mobilization for and with adolescents in the design and delivery of responses for adolescents. So the spirit in which we identified that particular cross-cutting theme was really in recognition from our own work and discussions of the fact that we're not doing as well as we can in partnering with adolescents, whether from key populations or from the general population in our programs overall.
Thank you. We're going to take one more question before we switch over to Tina and Monique's slides. And then for those who can stay on past the hour, we can continue the Q&A and discussion of application. So this question, Susan, is from Stuart Keene. He says, I'm glad to see the importance you place on sector synergies in addressing the need for stronger care, education, early childhood development, and psychosocial support. But this comes at a time when the care and support, not including cash transfers, is getting less attention in the global response. Will the All In campaign be advocating for more investment in care and support?
Thanks, Stuart, for your question. And the answer to that is absolutely yes. We are advocating for much greater attention to care and support as one of the critical social and programmatic enablers. In the framework that I showed, there were three boxes under what we're calling the interventions cluster. Within the social and programmatic enablers, we have critical structural enablers that make a difference for adolescents. Building off of the modeling that I mentioned, we have social protection, broader social protection, care and support as one of the critical programmatic, social and programmatic enablers. And we have it as an enabler with respect to HIV testing, treatment and care, because we recognize the difference that, for example, nutritional support, support to households affected by HIV, cash transfers can have on retention and adherence for adolescents living with HIV. But we also recognize the impact that these kinds of social protection supports can have on the impact from combination HIV prevention. So the social and programmatic enablers that we illustrate in this framework are seen as core to the results from HIV testing, treatment and care, interventions directly to adolescents living with HIV, as well as the combination prevention interventions. The other interventions within that cluster include interventions to address sexual violence, for example, and to strengthen availability and quality of broader sexual and reproductive health that is not HIV specific. So the all-in effort is going to be advocating for and working with countries to define a comprehensive package appropriate to each of their contexts that does include care and support, so that we can see more greater impact, but also more sustainable results for adolescents.
Thank you. Tina Monique?
Thank you so much, Dr. Susan. We really, really appreciate your time, your clear commitment and dedication to this age group, as well as just taking part of your time today to come and give us this presentation. And I do like to be a woman of my word, and so as I said, we would be sure after an hour. We are very much graciously releasing you right now, and we're very appreciative for your time.
Thank you very much, Tina Monique, and thank you to everybody for your time and for listening and for inviting UNICEF to share these thoughts with you.
Great. So,
and Tina Monique, you can just be a little closer to your mic. You're sounding pretty quiet.
Thank you, Sarah. Is that better?
Only slightly, but I know we only have a few slides here, so just please carry on, and everybody turn up your mic, or turn up your speakers, I mean.
Just increase my volume. We all know I don't have a problem with volume, so I'll speak at this level. for the remainder of the presentation. So I want to take us back one day, just to yesterday, the 1st of December, which is recognized around the globe as World AIDS Day. So for World AIDS Day 2014, we take this time to remember the people that we have lost. And for those of us that have been working in this field for a considerable amount of time, that number is many. So I'm asked right now if we can just have 20 seconds of silence to remember those that we've lost. Thank you. We also give thanks at this time for the progress that we've made in the area of HIV and AIDS. And we also commit ourselves anew to ensuring that no one is left behind. So we want to give thanks for the progress that we've seen over 3 decades of doing this type of work. So globally, infection rates have begun to decline. That's good news. For this, we are grateful. There are also fewer babies being born with HIV. We're doing a much better job with PMTCT programming. We've got more pregnant mothers that we're catching once they move to opt-out programming, such that all the pregnant ladies coming through the health facilities are being tested. When found positive, they're being initiated on treatment. And organizations such as ours, like World Vision, also advocating for what we call Option B+, whereby those HIV-positive pregnant ladies would not just be initiated on some type of preventive treatment for HIV for a brief period, but they would be initiated on that treatment for the rest of their lives. So we have 11.7 million people in low and middle income countries that are now on the life-saving antiretroviral medicine, or what we refer to as antiretroviral therapy. However, there are still challenges. We have 2.1 million people who were newly infected in 2013. We still have 22 million people who are not on ART, including 2 million children. People living with or vulnerable to HIV continue to face stigma and discrimination, such that stigma and discrimination for our prevention and treatment efforts. They also deny people in need access to comprehensive care and support. In terms of pediatrics and adolescents, we do know that worldwide the rate of pediatrics on HIV treatment are lagging behind those observed in adults. So whereby we've been congratulating ourselves on universal access and more people gaining access to treatment, those were more adults that were doing a good job of gaining access to treatment. But for the pediatrics, we still have quite a long way to go. And as Dr. Susan just mentioned, currently HIV is the #2 cause of adolescent death worldwide and the #1 cause of adolescent death in Africa. So, our question, how do we reach the children? We do know that there are many children still in need of treatment. In 22 priority countries, of the children that are HIV positive that need to be on treatment, currently only 1 in 3 of these children are on treatment. So we need to find them, we need to get them diagnosed, we need to get them initiated into care, and we need to get them on treatment and compliant such that we can see the following. The very good news is children respond well to treatment. So that's the good news part of it. So our challenge lies in how do we reach them and how do we get them onto the treatment when needed. So now moving over, progressing a bit into adolescence. This is a caricature of the adolescent brain. So whereas the areas that you see highlighted in the cartoon of what adolescents would normally tend to focus on: music, fitting in, self-image, love for their parents, thinking they know everything, sometimes having attitudes. All of those what we consider quote-unquote normal adolescent behaviors. These vary, however, when we talk about the adolescent living with HIV. For these adolescents, they're sometimes feeling isolated and depressed. They have challenges adhering to their meds. They have challenges in dealing with disclosure. They have challenges because sometimes they're still called upon to take care of others, especially other family members who may be in need. They may have challenges getting to the doctor when necessary. They have challenges coping with loss. And they have challenges dealing with stigma. So this next slide comes from UNICEF, and it talks about with all adolescents, when we consider adolescents living with HIV, their need to access a continuum of prevention, treatment, care, and support. And so you'll see the cycle here, starting from the top, diagnosis, onto initiation on ART, to adherence support, to disclosure support, to stigma and discrimination. These are the areas where most of the biological programs, the ones that are highlighted there in red, have focused currently. So we've got them entering into care, and then we have them initiating on treatment and then retention. So now let's move on and let's talk about what are some of the issues in terms of coping with illness and long-term care. They have mental health issues. There are challenges with psychosocial support, protection, care, and legal support, sexuality education, transition support, especially as they move from being in the adolescent group onto adulthood, and sexual and reproductive health. So in these terms, we have challenges dealing with adolescents in terms of their health and well-being, as well as their care as they evolve further from pediatrics to adolescents to adults. So what's next, or what do we do? I'm not sure how many of you have had a chance to do it, but there is a World AIDS Day message that's been uploaded onto World Vision Center. And in this message, I highlighted the parable of the talents that's found in Matthew chapter 25, verses 14 through 30. So most of us are familiar with that story, and we recall that the resounding message is that of how we are to be good stewards of endowed talent, skills, and resources. But that's not saying we're being called upon to do everything all at once. I mean, verse 15b tells us that each was gifted according to their own ability, which means essentially there's a purpose and a plan, and we each get to play our part to bring our unique gifts and talents to the picture. So we as World Vision can pull back and consider, well, what can we do? We're a child-focused organization. What's our calling? So I have here who will speak for these marginalized age groups, who will focus on root causes of vulnerability to HIV transmission and barriers to access to treatment or the very needed antiretroviral therapy. Who will create enabling environments, laws, policy, guidance, and tools to increase accountability and to close the gap. So if we pull back and consider an ecological approach, or what an ecological model might look like, we see here that there are levels or potential spheres of influence that radiate outward, from the individual to interpersonal to organizational to community to society and policy. So all of these areas create some opportunities for us to exert our sphere of influence. If you'll notice, one thing that is highlighted in red across all of these is stigma. So we still know that, unfortunately, in 2014, we are still referring to challenges in terms of stigma and discrimination for this population. But these slides will be uploaded, so you'll have more time later to go back and really lend further thought to this ecological model, to what ecological approaches might look like when we consider these things: gender inequality, unsupported schools, political inertia, weak linkages to care, weak referral systems, lack of trained professionals, or what we refer to often as human resources for health, loss and bereavement, disclosure, all the way down to the individual's intrapersonal level of coping with diagnosis, fear, anxiety about the future, mental health, sometimes substance abuse or poverty. So we come back to what can we do? The call to action refers to each of us individually asking ourselves, where can I fit in? What talents do I have to share? I suggest to all of us that there's still so much work to do if we are to reach the global goal of getting to zero. And that refers to zero new infections, zero discrimination, and zero AIDS-related deaths. So there's good news. An AIDS-free generation is within reach, and it starts with the children. I think now, if we were able to, Sarah might be able to play us a very brief video that highlights the adolescent. Sarah, is that possible?
One moment. Pulling it up.
Great, thank you. So that is a video that came from UNICEF that they've done in terms of working with the adolescents. And if you had more time, Dr. Susan has another part of the talk that refers to a smart investment and how essentially investing in care, prevention, care, and treatment of our adolescents is a smart investment for our collective future, because essentially they are the future, and that's why it's worth our time and attention to invest in them now, so that they can have very prolonged, healthy, productive lives. I am going to end now, and we can open it up for a few comments. We are beyond the hour, and we are trying very hard to keep it within the hour. So if anyone has a question, comment to share, I'll allow a couple of minutes for that now.
I'm just looking for hands or something in the chat box. We'll pause for a minute. I'm not seeing any hands, so perhaps no burning questions at the moment, but this is an open invitation for continued participation in discussions of adolescent HIV programming, prevention of mother-to-child transmission of HIV, and infant HIV programming. These are all things that the HIV and AIDS interest group, the Global Fund interest group, will move forward in discussing throughout the year. And this is an open invitation. If you are not yet part of these discussions and interest groups, contact me, contact Tina Monique, and we can certainly plug you in for future discussions. There are a couple of, I'll just take this last minute to talk to you a little bit about a few new resources. On WVI.org, we've had contributions from India, the Philippines, Kenya, Bosnia and Herzegovina. I'm missing one. Oh, El Salvador as well have sent in stories about their HIV programming, and they're up on WVI.org to share with friends on Facebook. Anybody who's in, along with these stories, we also have, of course, some of our foundational documents on HIV and AIDS programming, as well as others up on the web. So please share that with friends. They'll be coming in your meeting notes. I'll also quickly mention, I have to move over to this slide. We have a couple of COP webinars coming up this month of December. One, tomorrow, we're having our Healthy Timing and Spacing of Pregnancy programming discussion. So I hope you'll participate in that with us tomorrow morning at a very similar time. I think we start at 7 a.m. Eastern time, but check your inboxes, that should be there. Well, without any further questions, and we can hang on definitely for another minute if you have a burning question for Tina Monique or myself. Other than that, I want to say thank you for being a great participatory group, and we look forward to seeing you on the next WebEx. Thank you, Tina Monique, for helping arrange Susan to be with us, and we look forward to hearing more from the HIV and AIDS interest group in coming up.
Thank you, everyone, for your participation.